Hi everyone, welcome to Medicine for Dummies. I'm Dr. V. As you know, in my channel, I talk about all kinds of interesting topics for medical and nursing students. We started our pediatric case discussions a couple of weeks back, and today we will be going into our third topic. Keep in mind that this will be discussed in two sections, and don't forget to check out the second part coming soon. Of course, don't forget to like, subscribe, and share, and comment below if you want any other topics covered. So, let's dive in. Today, our topic is chronic kidney disease. This is a common disorder in children as well as adults. Usually, it occurs due to some underlying pathology in the kidneys, which lead to scarring and fibrosis, ultimately leading in the kidney being ineffective. We will discuss about the points in the history we should ask about, the examination findings we should look for, and what investigations we should order in these kinds of cases. Chronic kidney disease is defined as any abnormality in the structure or function of the kidney that lasts for at least 3 months. These abnormalities can be either something abnormal we see in a UFR or abnormalities in serum creatinine, something we detect in an ultrasound or any other imaging, or something we detect on a biopsy. And the important thing to remember is that this can be associated with or without a reduction in glomerular filtration rate. So, we can stage chronic kidney disease, or CKD, into 5 stages according to the GFR. So, we call it stage 1 if the GFR is more than 90, and stage 2 if it is between 60 and 89, and so on and so forth. It's important to remember these values because the management varies according to the stage at presentation. We can calculate the GFR in a pediatric patient by the Schwartz formula. It is K into the patient's height in centimeters divided by serum creatinine in milligrams per deciliter. So K is a constant and depends on the patient's age, as you can see here. CKD occurs due to a few pathological processes. When there is increased filtration through the glomeruli, there is damage to them and they become fibrosed. Then, the remaining glomeruli need to work extra hard to get the same effect, so the hyperfiltration will further increase, leading to damage of the remaining glomeruli as well. This becomes a vicious cycle, leading to kidney damage. A similar thing happens with hypertension, where due to the increased pressure, there is again hyperfiltration, leading to damage to glomeruli. Other factors like proteinuria, hyperphosphatemia, and hyperlipidemia have also been implicated in the pathogenesis. These patients can present in a multitude of ways. Most commonly, these patients are asymptomatic and are incidentally found through abnormalities in investigations. But others can present with constitutional symptoms like loss of appetite and lethargy, as well as increased thirst and increased urine output in the initial stages because of hyperfiltration. Children can have failure to thrive or growth retardation, and they can present with features of renal osteodystrophy like fractures. This is because the kidney is important in vitamin D synthesis and reabsorption of filtered calcium. A lot of these patients get anemia and associated symptoms with increased fatigue while playing, excessive sleeping, or poor concentration, and they can also come with acute decompensations in their kidney function. Some children will have increased blood pressure because of the fluid overload. When we talk about the causes of CKD, the list can go on, but here are the most common causes and causes of importance that we should remember. A lot of children with CKD in infancy or in the toddler age group have congenital abnormalities like PU valves, reflux nephropathy, or renal dysplasia. This makes them more prone to get kidney damage, fibrosis, and consequent CKD. Some children may have familial renal cystic disease or polycystic kidney disease, which is an autosomal dominant condition. Acquired conditions like nephrotic syndrome, glomerulonephritis, or atypical hemolytic uremic syndrome, which is when hemolytic uremic syndrome is not associated with diarrhea, can also lead to CKD in certain instances and should always be considered. Another familial condition we have to look out for is Alport syndrome, which is a nephropathy associated with hearing loss in children. Rarely, a bout of acute kidney injury, either following an infection or some other cause, can lead to CKD. So, what are the complications of CKD that we have to check for in the history and examination? As I said before, children present with constitutional symptoms like lethargy, malaise, and loss of appetite that may be due to uremia or other causes. They can get esophageal inflammation associated with reflux and peptic ulcer disease. They can also get uremia and uremic pericarditis and heart failure due to fluid overload or effects of uremia. Other features like pigmentation, renal osteodystrophy due to hypocalcemia are also seen. Hormonal imbalances and nutritional deficiency is common, so these children will get delayed puberty, growth retardation, and anemia related to erythropoietin deficiency. When the disease progresses and renal failure occurs, they tend to get metabolic acidosis and hypertension due to fluid overload and reduced urine output, as well as electrolyte imbalances like hyperkalemia. So, in order to diagnose the disease and look for complications, we do an array of investigations. If we do a full blood count, we will see a normochromic normocytic anemia associated with the erythropoietin deficiency. We can diagnose the condition by doing a serum creatinine level, and we may also see elevated blood urea because of the accumulation of products of nitrogenous waste. Then we may see certain complications like hyperkalemia and hyponatremia, as well as low serum ferritin levels due to associated iron deficiency. Serum lipids can be increased and serum calcium can be low due to the renal osteodystrophy. Due to the low calcium, PTH levels will be elevated, resulting in increased phosphorus, and because there will be a high bone turnover, there will be raised ALP levels as well. With the progression of the disease, acid-base abnormalities occur, so there will be a metabolic acidosis in the VBG. Other findings may be a low albumin level due to loss from proteinuria and poor intake, and with this, there can be an increased serum cholesterol level, because the liver tries to produce more protein, mainly lipoproteins, which will lead to the irregularities in the lipid profile. UFR and urine albumin to creatinine ratio are also quite important. Simple imaging like ultrasound abdomen can give a lot of details. The ultrasound features of CKD are threefold. There are small contracted kidneys with increased echogenicity and loss of corticomedullary demarcation. This is because due to the fibrosis, there is less fluid in the kidneys, so they appear more whitish compared to normal kidneys with altered anatomy. You can also see things like reflux, polycystic kidneys, and renal dysplasias with an ultrasound scan, and it is a simple, non-invasive investigation we can do in children with no radiation. So, that's all about how to take a history, examine, and investigate a child with chronic kidney disease. Stay tuned for the second part on management. Thanks for watching!